Becky, are you taking the question?
I will. Thank you, Chair, and thank you for the question. I can give you an overall allocation budget that we've received as a result of NHSE funding, and that is for 23-24, 1.246 million. The anticipation is that that will all be spent on maternity services across the ICS. Where it gets more difficult is being able to determine the amounts that are in the separate bit providers, UHM and QHB. Because of the way that we've got our contractual agreements and arrangements, there is a whole budget that's set over and transferred to the providers, and they are not broken down into separate services. So I cannot provide you with that level of detail at this moment in time.
Thank you, Becky. Tracy?
That's all the questions we've had. Thank you, Chair.
Okay, thank you. And Ian, thank you very much for submitting those questions in advance. Okay, so we'll move on to item 7 if we can, and I'm delighted to welcome Dr. Bala and team who are going to take us through an update on the Women's Health Clinic and local NHS GP practice initiative that's been taking place primarily around Adderley Green Surgery in Longton and Willowbank in Mere. And Bala approached me some time ago, a few months ago actually, to alert me to the work that was going on. And together with colleagues, Paul Edmondson-Jones, our Chief Medical Officer, and Dr. Lorna Clarkson, we thought it would be a good idea to invite Bala and the team from those practices today to come along and give us an update. And Bala, I think this is very pertinent today, actually, given the announcement yesterday by Victoria Atkins, particularly around the update on the women's health strategy. And just going through the slides that you're going to share with us in a moment, this seems to be really on point with that strategy and assisting those communities to actually realise the benefits of it. So Bala, over to you, and Bala, I'd ask you if you would introduce your team as well, please.
Good afternoon, everyone. Thank you, David, for having us, and thank you to all the board members for having us today. That's Dr. Sri Sundaram, and that's my practice manager, Mrs. Beverly Heath, and that's my practice nurse, lead practice nurse, Patricia Offery. Thank you. So I'm a local GP in Stoke-on-Trent, based at Mere and Longton. Is anybody moving the slides for me? Oh, okay. And we work along with the local authority and also the voluntary sectors as well. So what we do. So 3 main things that I'm a GP with special interest in women's health. So we mainly do the 3 important components in women's health. The one is contraception. The other one is the menopause clinic, and the other one is the smear clinic, really. So in contraception clinic, we do procedures like implant and the coils as well. And we also do the dedicated menopause clinic, HRT initiation and optimization. And once it's initiated and optimized, then our practice nurse follows them up every few months. And we also do some extra smear clinics than the routine ones. Again, through our practice nursing team, we try and do kind of out of our smear clinic for working women. We also do some walk-in smear clinics as well. And we also do some self-book smear clinics as well, so that the patient can choose their own time to come for the appointments. So we, apart from the routine clinics that we do, we also try and do some educational sessions and awareness sessions to the community and to the staff as well. And we do run some menopause cafes, again, in the practice and also through kind of, other hospital sites as well. We work along with the social prescriber team and also the health and the well-being team to deliver some menopause group sessions. Again, it's an educational and an awareness session. So yes, we do lot of collaborative working, and especially with our practice staff and with through the PCN health and well-being team. As I mentioned about the social prescribing team, they're quite active in our PCN. And again, with because we are based in Longton and near the Longton Library has been kind of very supportive for us to deliver some sessions, not just for our practice and our PCN. We've invited whole of the Mere and the Longton people for the menopause cafe sessions. We also did some blood pressure checks and the ECG checks as well in the library, just open to the public really on an evening session really. We did a couple of times there. And they have given us various other topics in line to be delivered in future. We also work along with the Cold Regeneration Trust, again with the social prescriber team to deliver the educational awareness sessions about not just about the menopause, about the the weight checks, the blood pressure checks, and general lifestyle and well-being really. So what have we done so far? We've delivered some webinars for the Merton Council in London, and again through the Worcester Council as well. And again with the Longton Library events, we've delivered quite a few of health awareness. And we've done a couple of sessions in Hoplands Hospital as well, again dedicated to the menopause. The feedback was really great. And again, we are planning to do some more in future as well. So what have we done in our practice? So we do a similar setting in our practice, mainly during the festive period, especially during the Easter and the Christmas time. What we do is we set up an open day on a weekend mainly, just to bring the whole family of operations. And we had a Santa in place for the last couple of years to deliver the Christmas presents. And again, at the same time, it was like we delivered the flu jabs, nasal flus, and pneumonia jabs and shingles jabs, and the vaccines as well. And they can have the health check at the same time as well. So the whole team was available during the weekend on their own time to entertain the families of our patients. And it was well received. And we're looking forward for the Easter event this year. Again, practice evening and weekend. Walk-in smear clinics. Again, a big thanks to our practice nurse, Patricia, who is here today with us. And again, the weekly menopause patients group, again, led by the social prescriber team. So teaching, I'm very lucky to have esteemed mentors like Professor Ruth Chambers and Professor Fidelma, who's trained me and since I was a baby doctor, really. So I'm happy to deliver the teaching sessions along with them. So this is a picture from the Longton Community Library where we had an evening menopause session. So Professor Vilma has finished her clinic, and this was a late evening at 7:30. We had this session, and it was well attended. Again, the feedback was really good. So this is just for the public, and we have done it for the midwife and the nursing students in the Kiel University as well. And we are planning to do some more, educational sessions for the nursing and the midwifery students as well. Not just again with the menopause, we are also planning to do some mental health, perinatal mental health, during the post-reproductive period as well. Again, self-care at the workplace. What we did was we gathered our staff during a lunchtime, and we checked all their blood pressures and ECG and weight, and discussed about the healthy lifestyle and living. We're planning to do some staff yoga as well, just for the health and well-being. And we had an opportunity, myself and Professor Fidelma has had an opportunity to deliver a menopause session through BBC Radio Stroke. It's just like a question and answer session. Outcomes, or maybe perhaps I would say it as our little achievements. Still a long way to go though. So these are the outcomes during the contraceptive clinic. This is from the Adderley Green surgery. The number of coil insertions that we have done during the last few years is, 62. And just to remind you, yes, it was during the COVID time, but yes, we were taking the appropriate precautions and things and continue to do the service because the demand was so high. And this is just to this has reduced a massive pressure on the waiting time from the other walk-in contraceptive clinics and also the secondary care clinics as well. Coil removals, again, 89, implant insertions, 138, implant removal, 128. In willow bank surgery, again, from 2020, from January 2020 till now, we had about 39 coil insertions, coil removals, 59, and quite a lot of implant insertions and implant removals because the kind of implants are quite popular at the moment. So we have started running a dedicated clinic just for the procedures itself. And this is the email that we received from the ICB recently. So PCN is the only one to show improvement in cervical smear uptake across the ICB. So again, well done to my team. I couldn't have done it without them. And this is just a snapshot of what we do in our clinic, really. So coil fitting removal, oral contraception, depot injections, and most of them is done by our practice nursing team as well. Menopausal support, HRT, pessary insertions and removal, and cervical smears, vaginal health. So we do this as an opportunistic in other clinics as well, you see. And we've been shortlisted for the BBC Radio Stoke Awards for making a difference in people's lives. And also we've been nominated for the Keel Partnership Awards as well. And I had this great opportunity to co-author this book along with my esteemed mentors. And this book is available in Amazon. And all the proceeds goes to suicide prevention charity. It's a very, very simple book about menopause, and it's very useful for the patients to deal. It tells us about how to help themselves, how to go through the menopause with simple techniques. And it also it breaks a lot of taboos and myths about menopause as well. Thank you for listening to me.
Well, I thank you very much. And it's interesting, every time I hear you talk about this, the passion and the energy that comes through is really infectious. And I think what your presentation demonstrates is just what can be done at a local level with teams making a difference with their local communities, in neighbourhoods, at place. And the other thing that struck me was the use of the community assets that you've got at your disposal. So many patients presumably would find it easier to go to the library and have an informal discussion with you rather than come into a medicalised environment where they may feel anxious or have difficulty. And secondly, just around the education side of it, particularly for practitioners coming through either from Kiel or wherever, again, really important. And that holistic link that you've raised between mental health and physical healthcare, so important. And it might be just worth taking some questions now, but just while we're taking those questions, Bala, just in terms of winning the trust of some of your communities to actually get them to come and present to you in the first place, to have these very important procedures and screening undertaken. Just say a few words just in terms of, how obviously you built that up with the coffee mornings, the open days at the practice, really opening the window on this to people and the benefits, but just anything else you'd like to add, because I think there's some wider learning there.
It's not been an easy ride. Again, it's a kind of it's a more of a team effort, really. So when we see them out of our routine clinics, say for example, the Christmas event and the Easter events on a weekend on an informal setting, has made them more approachable to us and to our practice team as well. So during those times, we had some informal questions about the menopause, about the contraception and the depot injection and the blood pressures and everything. So we were available to answer them, and we booked them in the clinic. So that was again to break the barriers as well. And what we did was we had reached some of the community leaders as well, because there is a lot of myth about smear and things like that. So we approached the community leaders to help us with the smear taking as well. We have got a multi-ethnicity population. There are a lot of language barriers, and we have started sending them kind of messages and leaflets available in various languages. We approached the smear psychology team to send us some leaflets and things. So those little things has been helpful to improve the smear uptake and the contraception uptake and the menopause as well.
Thanks, Bala. Really helpful. Julie.
Thanks. Feels a bit rude, so hopefully you can hear. Just thank you very much. The motivation is great, and it's great to see exactly what you're doing at your clinics. But given the recent changes with pharmacists and the ability for them to provide contraception, I just wondered how that was going to impact on the services you provide, the relationships with local pharmacies, but also something that I've been thinking about: when pharmacists actually diagnose or prescribe the pill, how do they take into account medical history that could impact on the choice of contraception?
I'm not sure about how the pharmacy clinics are run and who is manned by and what kind of governance they have in place. But what we tend to do is, say, for example, if they're already on a particular kind of contraception and if the clinic is overbooked, then we ask them to go for the contraception walk-in clinics, which we have in our own kind of center. So we find them safe if they've already been established and optimized on a particular contraception. If they want just like a pill check and a repeat prescription, then that's fine by them. But if they want to start off on a new contraception, we try and encourage them to book in with us with a clinician or a healthcare or a practice nurse. Yeah, in that way we reduce kind of any errors or anything to be done really. But I'm not sure about what governance and systems the pharmacy have in place.
So pick a bit more up from that as an action, if we could, Tracy, from today, that'd be great. So I've got Tracy.
Thank you, Bala, for your presentation. And, it's fantastic that we've got people passionately supporting women's health and the work on menopause and keeping women in work during that period, and the prevention with the smearing, etc. All fantastic. And whilst recognising that GP practices are independent practices, this is really important stuff. And I was just wondering if there was anything that was happening to try to roll out the excellent work that you're doing, or share what you're doing with other GP practices as well.
We are hoping to do that. It would be great if we do this in a massive scale, but again, it has to be with the help of the hopefully with the help of the ICB board. I think we could roll it to other PCNs and in a massive scale as well. I'm sure some of the GPs are doing this already, so it would be great to kind of get along together and do this. Yeah, thank you, Tracy. And Tracy has been seeing me since a baby doctor.
Thank you, Chair. And it's a little bit linked to the question you asked earlier. We know what the demographics are in terms of how diverse a community Stoke in particular has, and some of the significant challenges, particularly around very deprived communities as well, particularly from an ethnic minority background. And I just wanted to really ask, clearly you're trying to break those barriers down and be as inclusive as possible, particularly to those groups that we know won't realistically maybe take up healthcare in the way that other communities would. Do you have particular challenges with particular communities, bearing in mind we have so many different new and emerging communities arriving in this country and arriving in Stoke as well?
Yeah, as I mentioned before, we are a multi-ethnic population. So it's kind of quite different. We've got a lot of South Asian community as well. And the beliefs are kind of quite, we had another patient, Pat was telling me the other day, this patient doesn't want to have a smear just because she's not married yet. And that's in their culture, really. So Pat has to have a lengthy conversation with her to bring her for another appointment for the smear clinic. That's another one. And the other thing is, no, I don't have, I don't have multiple sexual partners, or I don't have a sexually transmitted infection. Why do I need to have a smear? So again, it brings us to another little conversation before the actual smear taking process itself. So we kind of, and we've got other communities. No, I have had it in my country. I don't have it here. So that's another thing really. And the other thing is language barrier. So it's not just about the ethnicity and things like that, but the other population, like, uh, females who are autistic and with learning disability as well, we spend kind of extra time with them. So they usually get a double appointment or the last appointment, so that the nursing team can kind of support them and talk through them, or ask them to bring another person along with them. So those kind of little things that we do. And as I said to you before, like we included their community leaders. We spoke to the person who's in charge of the mosque, and to encourage smear taking in their own community. And that has improved the smear taking and the flu clinic uptake as well. So little things, yes, but it does take a lot of time, but it is doable. That's what. Yeah, thank you.
Thanks, Shaukat. Mish?
Thank you. And thank you so much for your presentation. It's really interesting. My question is really linked to what Tracy asked about the spread of this, and with a workforce lens. I suppose I'm interested in what advice you would give other PCNs, other practices, particularly in the field of menopause, in terms of how you've helped your teams and your staff to understand this. I do think that the offer of support around menopause does vary a lot across the country. So I just wonder how you have approached that, and what advice you'd give others about your workforce learning, understanding some of that.
So it's a lot of learning process for myself before we set up this menopause clinic. So we spent quite a lot of hours in kind of learning about, and it changes every day as well. It's kind of updated every day as well. So I'm a member of British Menopause Society. So once I get the email or any kind of update from them, I share it within my team. And we do run like a fortnightly clinical governance meetings in our practice. So where I share my kind of learning along with the whole team. And it's the same thing for everybody. If my practice nurse does a educational session, she shares the learning bites during that time really. So this is what, again, it's just educating and upgrading ourselves with the current menopause guidelines and contraception guidelines and everything. I think we do have some protective learning time where we had some menopause sessions teaching, but that alone is not kind of as enough. We need to do a lot of personal development things to do those kind of clinics, and I'm sure this is doable. Thank you.
Thank you.
Thanks very much. Final question, Paul.
Thank you, Chair. Just to come back on the question that was asked, I think it was Julie that asked about the question on pharmacy, I think, and contraception. Happy to pick that up and maybe get Mark Seaton to do a little bit of a briefing on pharmacy first, how all of that works, how things are done, what's done there, how do we keep it safe and so on. So I can pick that one up. Second thing was just to say, Bala, thank you very much for presentation. This is great, isn't it, when we see sort of primary care leading the way, an individual within primary care leading the way, innovating, creating that good practice, and it's great to see you promulgating that good practice. And it comes back to what Mish was saying again about how do we then pick up that, build on what you do that at scale, systematically, right across the whole of Staffordshire and Stoke-on-Trent. And I guess that's something, and Victoria Atkins was saying yesterday, wasn't she, about how that was one of her sort of five things. Tracy, you picked up on the sort of the links, primary, secondary care. We need to link this back into maternity care. Huge amount of work being done at the moment on preconception, for instance, and sort of looking at these different things. And we need to stitch this together, make sure that we've got the right shared care agreements, that we've got the right protocols and pathways between us. There's so much we can do to build on what you're doing, and you're very much a sort of vanguard in this and so on, and it's great to see. So thank you.
Well, thanks for that, and just I guess on the back of that you will make sure that Bala and the team are actually linked in through Lorna with that work, because as said at the start, this is infectious. And it's the real essence of transformation. Actually, we can have the trappings of all the plans, but actually it's the people on the ground in their communities, harnessing those local assets that actually make the difference. So Bala, and to all your team, well done, and thank you very much. It's great to be in the city of Stoke-on-Trent this afternoon and hear such an inspirational story about work that's going on in some very challenged areas in the city at the moment to improve the outcomes for the patients and the communities there. So thanks very much. It's been great to see you. You're more than happy to stay for the rest of the meeting. If not, we will release you.
Thank you very much for having us.
Okay, thank you, Bala. Okay, we'll move on, if we can, into item 8, the Chair and Chief Exec's report. I'll hand over to Chief Executive Peter in a moment. Just wanted to pick out a few things, if I could. I just wanted to make reference to the King's New Year Honours List. It was good to see that people had actually made that list from across our catchment area, and congratulations to Chandra Kanaganti and Abby Brown and Elaine Hutchings for their honours received during that time, and also Karen Bradley, the Leek and Staffordshire Moorlands MP, who was honoured in the political awards. Secondly, I just wanted to make reference to some of the people who are leaving us, and I said to Tracy Bullock earlier that I'm not going to embarrass her completely today. That'll wait until we get further down the track, Tracy. But I think it would be absolutely fit and appropriate to recognise the contribution that you've made, again, into a very challenging area of work during your time as Chief Executive. And I'm sure there'll be plenty of opportunity to come back to that, certainly through the board and elsewhere going forward. I also wanted to just acknowledge as well, David Rogers is stepping down from Combined. David's announcement just missed the deadline actually for the report. That's why it's not in print. And again, immensely grateful for David for the leadership that he's shown to Combined Healthcare. And again, we will wish David all the best today and in due course as he comes to retire from Combined Healthcare. So Peter, if I could hand over to you just to pick out any exceptions you want to pick out. There's quite a bit in the report that's covered in detail as we go through the agenda, but any escalations you'd like to make now?
Yes, thank you, David. So firstly, I'd like to second the praise you've just given to David Rogers and Tracy next to him. As you say, lots of opportunity to embarrass, but I think it's an important point to note. One other thing I just wanted to mention in terms of the report, and actually there isn't a lot of detail in the report itself in relation to this, but there are documents on the agenda that do touch on it, is planning. So of course we're in Q4 now, which traditionally is the point at which we immerse ourselves into the planning process for the coming year. And I think it's fair to say that the whole of the NHS and social care, of course, are finding it challenging at this point in time in relation to both this year, but also the planning cycle for next year. So, but we will endeavour through the next couple of months to do absolutely the best that we can to build solutions that provide the best services, provide the best financial solutions, operational solutions for 24-25. But I just think it's important at this point in time, given the position that we can see, to indicate the level of challenge and difficulty that we suspect next year is going to bring to us all. So, it's a commitment to the population, to the public, that we will do the best that we can. And we only had a conversation a couple of hours ago as a group of chief execs in relation to this. But it isn't looking easy at all, given both the financial climate and, of course, the legacy still in terms of COVID that we are all coping with, you know. So there are a number of factors out there that are, I suppose, I'm describing them as extraordinary. But I think given the level of inclusivity that we've got in terms of the process, the level of quality of data, evidence, puts us in as good a position as any system across the country, but it is going to be tough. I'll leave it there, David. Thank you.
Thanks, Peter. I've got a question from Julie. Julie, can you just check your mic? I think it might have just gone to another. That's fine. It's flashing. Is it working yet?
Oh, it's flashing at me. Oh, it's working now. That's all. Not usually thought to be quite. So that there was the learning from that particular audit report. The other thing I just wondered, in terms of the figures that are quoted within your chief exec report, we can see the trend over the course of the year, but I just wondered, given that we're in winter, I suppose I'm looking at Phil here, I think it might be useful in the next report to see a comparison of December 22 with December 23 in order to just demonstrate, hopefully, the improvement and to be able to explain. I just think that might be useful.
Yeah, thanks, Julie. I think that is useful, and I think Peter will be able to pull that together.
So yeah, on the second one, that's barn door obvious, but somebody has to say it then to make it happen. So absolutely, because I think in terms of whether it be UEC or of course the elected position, I think we're doing a lot better now. Of course, not surprisingly, the good people at NHSE will push us to do even better, kind of their job to an extent. But yeah, we are doing a lot better. SpecCom, yeah, so the theory is that a number of services will transition over to us for commissioning purposes from the 1st of April. There is a lot of learning from the pod delegations that we are, I think, still learning from. As a West ICB Chief Executive Group, we've commissioned that learning piece from Hereford and Worcester, who are the lead for pod, and that work is still ongoing. I am really conscious that we haven't got long now before that transition point, of course, theoretically occurs. What I've been very clear with the West Midland chief execs on, and I think, you know, the conversations within our team, exec team, is that if the risks are too significant, we should not transition the commissioning over and go with, I've got in my head 3 out of the 7 regions are provisionally going to transition this time, but the other 4, for whatever reason, have chosen not to. So they're not going until, what, April 25. So, you know, I think we need to be strong in this. And if there is sufficient risk on the table that indicates we have a problem from the 1st of April, if we do go with delegation, I think we should say no. But the key is the due diligence detail to support the decision-making process.
Yeah, absolutely. Yeah. That is a key point there, that due diligence, Peter, and thank you for responding to that. Megan.
Thank you. Just a question in relation to people, which is set out under 1.4. I could have asked this at various points actually throughout the agenda, but I thought I'd ask it now. So it's just in relation to the NHS England long-term workforce plan, and your report talks about the fact it outlines the biggest training increase and recruitment drive in history, with a potential increase between 22 to 30% such as Stoke-on-Trent. So my question really is how that fits with the financial position of the system and the need to deliver a balanced position.
Getting all the best questions today. So it's difficult, isn't it? I think there's further reconciliation to be done between the money, the workforce, the operational position, to fully determine what the numbers are that we require going forward. The NHS often pushes you down a 1-year planning process, which just doesn't cut it frankly, in terms of particularly the conversation around the long term. I mean, the things in the title, isn't it? Long-term workforce plan. So there's something for me about this time round. Yes, the operational plan is really important, but I am pushing colleagues to pull together a 3 to 5 year equivalent version that pulls together more intelligently that piece between workforce, finance and operations. And as we always say, it's a three-legged stool. So all three elements have to be, working in unison to make it operate effectively. So I think as that work progresses on that medium-term broader plan, I'll be able to answer the question more eloquently.
Thanks, Peter. Thanks for the question, Megan. Can I just check everybody happy? Josie? Yes, I know it's quite difficult without the yellow hands to spot people, so please do make sure you put your hand up if I miss you.
Yeah, and others may want to come in briefly, but I suppose the way I see the world in terms of efficiency and productivity is that there's three environments that we deliver that through. So one is within each organisation. So each organisation will have its productivity efficiency programme that it will look to deliver in the year. The second environment is system-wide transformation. So this is kind of whole pathway stuff, which is still relevant, I think, to the workforce productivity piece. And then the third area that perhaps we're a little bit behind the curve on in terms of the NHS, not local authorities at all, but it's the locality piece, the localised agenda. So all three of those elements will have a level of workforce productivity and efficiency within them. Perhaps, in my mind, I see the first one of those three as being the most relevant, but I wouldn't say that it's the only area, i.e. the in-organisation productivity opportunity. I think all three elements will be relevant, just in slightly different ways. And the second two, of course, are the, if you like, the less traditional ways of doing it. The first one, in-organisation productivity, it's been around for quite a while, hasn't it? So yeah.
Thanks, Josie. Mish?
Thank you. And, Peter's answered the question, but I think just to add to that and to reference the question that Megan asked as well about the long-term plan and the fact that we're struggling financially, depending on how you see it in terms of our ability to deliver all of that workforce, productivity massively comes into that. So the long-term plan is a national document that focuses primarily on registered roles. So within our area, we have considered what we need from a medium and long-term perspective. Yes, there will be a requirement for more registered roles, but what we will need to do is to consider our skill mix and how that adds to the overall productivity piece that Peter has referred to. So it won't always be the traditional roles, and it won't always be those colleagues working in the way that they were working before. So as Peter has described.
Thank you. John?
Peter, could I ask whether the NHS England National Planning Guidance has been published yet, given we're only just over 2 months away from the start of the new financial year?
Green now. Oh no, I've gone to red. Marvellous. Right. So not in detail yet, I don't think, unless no. So yes, it's disappointing, isn't it? Yeah. I don't, Paul, do we have an idea? Date?
Targets that we know about. So, Phil, we're fairly clear, I think, in terms of operational expectations. Draft allocations were set out before. So, in some senses, it's obviously not helpful. But on the other hand, I think we're pretty clear in terms of the key direction for the NHS and what's required of us for next year, and we can carry on with our planning on that basis. I think it'll be more around sort of tweaking some of the planning assumptions down the line than a fundamental change.
Yeah, thanks for the question though, John. We are meeting the regional team tomorrow, and we will pick that up, no doubt, with Dale Bywater, the regional director. Okay, any further questions? No. Okay, everybody happy to move on. So we received the Chief Exec and Chair's report. Item 9, important report, is the PricewaterhouseCoopers report on financial recovery, our plan and our grip and control on the measures to bring us back into financial health. So Paul, can I hand over to you?
Yes, thank you, Chair. So this report was commissioned by NHS Executive England, on the back of us indicating that we didn't think we were going to be able to deliver a balanced financial budget in the current financial year. At that time, you might remember that we were looking at an outturn of 141 million. We'll come to the report a bit later down the line in this meeting, but we're currently, the recovery plan is having quite a substantial impact on that in terms of bringing the position back to 91 million, but that's still obviously not a break even. But the report was commissioned in that context. I think we broadly, you've read the report, I hope, broadly support the report as being an accurate portrayal of our system. There are bits about it which are positive, which I think we would recognise, and there are bits where there's work to do, which we'd also recognise. So the bits that are positive is that the report recognises that there's a very strong collaborative. They went around the system and spoke to all our partners, and a strong system understanding of the recovery plan and the focus on CHC, and that endeavour is supported throughout the system, and that's obviously a very important thing. On the governance area, they were positive in terms of us following good governance in terms of the oversight, the use of Finance and Performance Committee, the way we work as a system on governance, and how we connect governance between individual organisations and the system. Thirdly, on the workforce point, which we were just covering there, essentially their words were a level of grip and control, which I think is saying there is grip and control, but there's more to do, which I'll come on to in a second. That really around the hiring of people and the use of agency. And lastly, support for the double lock that we put in place in terms of the use of that in terms of robust challenge, with the words that they use. There is robust challenge by partners to other partners within the double lock mechanism. And separately, we're looking, Megan, at the committee, that way that double lock works. There are some learning points, but in terms of the the test that the PwC was set is the challenge in the system when business cases are put forward. The answer was yes, there is challenge, but there are some areas for improvement, which again, as I said at the start, we accept. The first one is around greater detail around the phasing of metrics, and particularly making those more granular. That's what we're working on. Chris Sands, who's CFO at MPFT, is developing a tool, a benchmarking pack, which does that, and it's starting to look really good. But we accept that recommendation. We do need a stronger set of metrics and phasing. Secondly, and again, we accept this one, I think, Neil, need to speed up some of the implementation of the CHC measures. So we've made a really good start, but there's need to pick up the pace even more in terms of delivering the impact. Next, that should be more of a benefits realisation process adopted by the system when we do put in business cases. Next, more of a standardisation of control between organisations. So they found good practice broadly, some areas where there's particularly good practice, and they're suggesting sharing that across organisations. And finally, further detail around some of the workforce metrics. So overall, Chair, we do accept the findings. Those have been discussed at Finance and Performance Committee. Finance and Performance Committee asks that we review quarterly, and in a quarter we come back to look at how we're doing against those metrics. The report's also been shared with the national team. I think that's helped. As I'll again come on to talk about in a bit, we have now received approval for our in-year financial plan of 91 million deficit, and that was in part because the report found the things that I've just reported back.
Okay, thanks very much, Paul. Just before I open it up to questions, Just a couple of key points. I'm sure this is the case. On page 7, we've got the key recommendations for the board. I'm taking they are embedded in, the objectives and actions that we already have in place, both financially and across any of the other reporting committees to the board.
Yes, they are. I mean, there are some of these that builds on what we've already got in place, and those are the recommendations that we're putting in place as we speak. And as I say, in a quarter's time, Chair will review how we've done against those. So some are already there. You're right. Others we're putting into place now.
Yeah, and the second point, Paul, which is something that comes up very often when we meet, and I'm sure it'll come up tomorrow with the quarterly review meeting with the central team, is just around the bank and agency controls. And on page 22 of the report, there's a breakdown there, particularly about, is it off tariff or off spend, where we're actually off framework. Thank you. So what I wondered about that was just looking over at my colleague Julie Holder, whether the audit committee might just want to have a bit of a look at that as well, just to make sure that we have really bottomed out that argument. So I'll bring Julie in a moment when she asks the question. But Paul, Mish, if I could just ask for a response on that.
Yes, I mean, it's part of the work, David, that we're looking at is the use of more on framework, and it is an area where there is some room for improvement. So absolutely, it's in the work programme. Okay.
So anything we can do to just get that narrative into a place that we can present that back centrally, because it's something, particularly on the regional chairs meeting a week ago, the collective group was being challenged very much on agency spend, and where it was slightly off beam, so to speak. So that is an important piece of work. Julie.
I'm red again. No. Oh, I want to be red. That's right. Sorry. Sorry, just picking up your point, it was sort of what I was going to refer. I think it's a really important piece of work because it's independent at a point in time, and it has helped with supporting the position that we're now, I think I heard you say, has been accepted as the forecast outturn. My question was going to be around taking assurance about the implementation of these recommendations, but also again in audit committee we heard a further update from our internal auditors about efficiency reviews, some of which are similar, the recommendations. So I just wanted some assurance that Finance and Performance Committee are monitoring the implementation overall of those recommendations. And certainly I do think there's a bit of added value. I know it perhaps doesn't feel that, of audit committee looking at the area of agency independent of finance and people committee, is the audit committee giving some different people around the table, different views around being able to support and understand where we are on agency.
Yeah, thanks, Julie. For
sort of looking at Megan as well when I say that, and
so Megan, do you want to just respond on that from the Finance and Performance Committee perspective?
Yeah, no, absolutely. I agree, Julie. I think they're very helpful. And the internal audit reports will come to Finance and Performance Committee. It hasn't yet, but we will make sure that it does come and follow that up alongside this.
Okay, and I'm sure Showcat wants to come in now, but that would be linked to the People Committee as well.
Yeah, Chair. Mish is going to respond to the sort of the agency bit, but I've got some more general questions. So, okay.
Thanks, Mish.
Thank you. Thanks for raising that in terms of the agency spend, particularly off framework. That there are robust plans in place in each of the providers to reduce the agency spend. Actually, the NPFT as an organisation has reduced their agency spend by 26%, and within that, off framework is a massive part of it. Off framework tends to be used in the areas where there are limited medical cover where required, where one-to-one care is necessary. Also within the acute sector, absolutely within the escalation wards. And also in elective recovery delivery. So what we have is each of the providers with their individual plans in place, and there really are robust plans to ensure that we monitor the agency spend both from an a non-framework and a framework perspective. B, we try and get people onto the books where we can, that we're aware of each of the areas where there are long-standing and particularly expensive individuals working. So this has been monitored weekly by region. We get the feedback, but also our team are looking at that ourselves and linking with the CPOs on that. All of that information comes through the People Committee and also to Finance Committee, and more than happy to have a conversation about how that might link into audit as well.
Thanks, Mish. Showcat?
Yeah, thank you, Chair. So I've just got a number of points, Paul, really, in terms of the report that's been presented. One is a question around ownership, and because clearly, if this is going to really work, it's about ownership across the system. And you know, at times it can be quite challenging when a consultancy comes into the organisation, makes a series of recommendations, and about how the workforce across the system really embraces those recommendations and that ownership is there. The other thing really is because there's a lot around in there about grip and control and moving at pace. And for me, there's a question really, and quite a bit of emphasis on the executive team in terms of ownership and responsibility, but it's the bit around capacity and about have we got that capacity and do we need to bolster up that capacity, which again is challenging when we're talking about, from a workforce point of view, bringing in a range of controls. And then finally, it's the point you made about metrics. So whilst there is some detail there isn't a clear line of sight against the recommendations about, well, by the delivery of these metrics, this is what we will achieve, these are the outcomes. I'm assuming somewhere there are action plans and papers sitting behind that, but I think in terms of that grip, control, and that bit around the ability to track the savings, those metrics aligned to what they will deliver, it's going to be quite critical and key.
Okay, thanks, Showcat. Pat?
Chair, thank you. A good report actually, which I fully support. It's a note rather than a question really. It relates to the recommendation number 1, the finalised benefits realisation and the non-finance metrics. I think there's something that we should be trying to impress on ourselves as a system anyway, that should just be a standing expectation in any business case, in any delivery plan that we do. You know, finance either going the wrong way or the right way doesn't happen in isolation. There are stuff that we do, so let's measure that stuff. And there are operational, clinical, or whatever benefits that go hand in hand with the finance, and we should be matching those. We should be monitoring those. Also, it strikes me there's an issue around the benefits realisation, also the risk tracking. You want to be understanding the ramifications of your actions and making sure there are no unintended consequences. So again, the non-financial metrics monitoring becomes hugely important in that. And finally, I think we should also impress the expectation is when these things happen. So the measurement of metrics in time. We hear a lot in plans like this that initiatives are back-ended to the first, quarter 4, whatever. Well, that's not really good enough, is it? Because you've lost 3 months worth of potential benefits. So also, and getting into the routine, if we don't already have it, and we may do, my apologies, that both the financial and the non-financial benefits or the things that we can't want to see, that they're actually, what's the word I'm looking for? They're stated when within the year, so that we've got a view as to whether that's acceptable in terms of timeliness of delivery, as well as the actual ultimate delivery. Thank you, Chair.
Yeah, Pat, I think really helpful points there, and the tests that you identify, Paul, presumably some of that will be built in, but I think the added discipline of just revisiting that on a regular basis and, reviewing and reinventing our processes in the light of experience, critically important. And going back to what I said earlier, Pat, about the narrative, we can give confidence externally that we have the grip and control that this report was examining. Applying those tests will help to deliver that. John.
So I was actually going to make the identical point to the one that Pat's made. He made it better than I would have done. But I want to just make a connection then between the point Pat's made and the point Showcat's made, because I think getting more rigour around benefits realisation, setting of trajectories will actually engender ownership. That's my experience, is that when you see the numbers, when you see the progress, when you see what's behind where he said it would be, when you're able to compare to the business case, that's when you can actually meaningfully challenge and speak into that space on a sort of collegiate peer basis. So I think the absence of a systematic approach to business realization is a key gap. I think PwC absolutely right to call it out, and I think it's our responsibility to put it in place as soon as possible.
Yeah, Pat, thanks, John.
Sorry if I may come back, because what John just said has sparked a thought as well. And it comes back to that point of accountability and checking through the various committees. Now, excuse me, because I don't know the way that it works within an NHS system. But also, when all of this is defined, should this not then be built into the annual targets of all of our staff colleagues? If you are an executive, if you are a departmental lead, if you're a clinical lead even, then actually this is what we've signed up to deliver. This is what we're expecting you to deliver. So we then do, cascading through the whole system, we have that series of accountability, which should further, if it's checked and if it's traced through and if people are held to account, it should further both put everybody on point. It's a big deal coming in on budget, but also be holding them to account anyway, which is just good practice.
Yeah. Okay. Thanks, Pat. Again, very interesting, important point that you raised there. So, can I just check, are there further questions or any comments anybody wants to make before we draw this to a conclusion? Okay. So, Paul, thanks for the presentation. Just in terms of the recommendations that we've got in the report. To note the findings and additional recommendations of the independent assessment. I think we need just to take those a bit further in terms of granularity, and particularly in terms of being very clear. I think Josie raised the comment, as did others, around where this is owned and fits and how it all comes back together through the executive through to the board. So if we could review that. The points that both Pat and John have raised, just around the benefits realisation, risk tracking, and the measure of the metrics, and when that happens, and again in the granular detail. Can we just do a review? And Peter, I don't know again whether initially that is a chief executive discussion with chief finance officers, because obviously Pat did make the point about the financial risk and non-financial risks here in terms of the way that goes forward. So I think there's a further piece of work to actually probably bring this to life, make sure it is fully embedded and that we are continually driving that narrative. Peter.
Yeah, so we'll make sure that happens. I think work, frankly, beyond the point at which we received the PwC report, work has already happened to sort out a lot of what was recommended and described in the report itself. So I wouldn't want to kind of end the conversation with doom and gloom, if you like. But yes, so we'll monitor delivery of the PwC recommendations through F&P and through SPC, a lot of acronyms. And, I think our PMO arrangements, another acronym, but the Performance Management Office arrangements that we use to deliver and manage a lot of what we're talking about here are really, really effective. They're essentially an offshoot of NPUFT's offices. And, I've been really impressed with Alex and the team's management and delivery to date. Clearly, there's more that we can do. The PwC report suggests that, and I fully support the comments made a moment ago in terms of triangulation, holding to account, etc. But I genuinely don't believe that we're in a bad place in relation to this. I think that there's more work that needs to be done. We need to monitor the report recommendations, but we are in a decent place, I would say.
Yeah, and just to go back to your point, it's not to preach doom and gloom, as you say. We are on a trajectory, but I think what the report does, it actually sparks our curiosity in terms of our processes and how we work, and I think it's a timely opportunity to take this not only as part of the financial recovery plan, but also into the governance review that we're going to talk about later on this afternoon, just to continually be thinking about how do we fine tune our processes to make them more effective. And just finally on the recommendations, if we can just add in the point about the audit committee and the agency spend piece, just to make sure that that's followed through as well. Okay, so everybody happy on that basis to move forward, and this will be something that we will return to on a regular basis. So if everybody's happy to move on, we'll move into item 10. The system governance and performance review, and Becky, you're taking the quality and safety report, I think.
That's right. Thank you very much. I'll just highlight some of the areas that we've outlined within the paper that you've received. So the deep dive discussions which we're undertaking at Quality Safety Committee, they are rich discussions. There is a lot of information that we can actually play through in a very robust manner, and we are also gathering that intelligence with regards to those quality impacts of changes, or instances where people wish to discuss the issues that are outlined within certain pathways and certain services. Going on from the updates that we receive at System Quality Group, there are a couple of areas that I just draw your attention to. One is the good work that's continuing to happen around the deteriorating patient network. That's a system-wide programme supported by all providers and local authorities, and really does start to hone in on some of those really important points for care homes, educating, signposting and supporting navigation. It's proven to be really impactful in terms of being able to support those nursing homes to access the services at the right time, and they continue to roll out that resource pack which provides all of that information to our care home providers. Secondly, just a reference in terms of an area of pressure within the heart failure services within the community. That's been work that's been ongoing within MPFT. They have a number of actions and mitigations that they've agreed at board level. They've got a consultant cardiologist that's commenced a comment and is going to have significant impact upon the weights that we've got within that area. And they're also got a number of actions that safety net our patients that are sitting within that waiting list as well. North Staffs Combined highlighted that they are continuing to progress with the mandated move from the care programme approach within the community, sort of working collaboratively across the local authorities and other providers to ensure that the standards and the rapidity, the responsiveness, the flexibility that's required within that planning process is maintained, and the focus continues to be on supporting our citizens and service users. There is reference within there about the app that's being rolled out. That should be in place by the end of January, and that's about making accessibility one place where all the records are maintained, and also sort of providing the user with an awful lot more information that they can access whenever they need to move things forward, or to identify areas where they wish to respond to a key worker in a different way. Health Watch are a really important part of our our committee and group. They support us in keeping that patient voice in the centre of all of the discussions that we have. They've been undertaking some deep dives themselves, particularly around access to primary care, coming up with really positive and useful feedback which we are sharing across the system, and also looking at sort of patient experiences. They've recently been in maternity services over at UHM and identified with the staff sort of well-being and how important that is in terms of maintaining patient safety and patient enhanced care. Lastly, I'm going to just draw us to the quality assurance and improvement, and that's just to outline the fact that whilst vast majority of patients will receive care within Staffordshire and Stoke-on-Trent, we very much recognise that those areas outside of our borders are also an important part of the provision. So we just outlined there the kind of contractual and conversations that the quality team are undertaking to ensure that we've got that assurance and we're involved in the improvement programmes and can see the links and synergy across the whole of the systems. I'll leave it there, Chair, and take any questions.
Thanks very much, Becky. Full report there. Just a few points, if I could pick them up with you. The first one was, it was really pleasing to see the work around the resource pack in care homes. And I think that was just for Staffordshire. Just wanted to check if there's a similar approach going on in Stoke.
Yeah, that one covers the entirety of Staffordshire and Stoke-on-Trent, so it will cover the, yeah.
And just a subsidiary point, if I can, in terms of access to training, if we're running training programmes, are we enabling care home staff to attend those training sessions as well?
And actually, some of our services are going into care homes to provide that, because we recognise how difficult sometimes it is to release staff to do training either on a platform or in person. So some of the services are engaging directly with our care homes and going in and supporting staff to understand how to access the pack, and also the resources that are available to them to be able to support patients in a positive and proactive way.
Thanks, Becky. The second one, under 2.2, the challenges linked to the heart failure service are set out there with some of the waiting times. And I guess just wanted to check what communication there is with patients, what communication back to primary care, and through Paul may be able to help with this, just in terms of the medical examiner role. Yeah. Just in terms of how any mortality issues may be being managed while people are waiting on the waiting list for that service.
So in terms of communication, there is a process that's been undertaken within that service where they have clinical conversations with the patients on the caseload, and also those that are waiting. There's also a harm review that's been undertaken, and with the consultants, they identify those high risk or urgent patients and do have as part of their caseload and conversations, do contact the patients directly. So there is evidence that our patients are aware that there is a wait, but also that we are doing that prioritisation and urgent review also as part of the action plan that's been put together. There have been some generic comms across the GPs, PCNs about, sort of priority patients and the issues and pressures that are within the heart failure service. So as much as possible, we are communicating, MPFT are communicating, and I'm sure Neil can add to that if necessary. With regards to the mortality reviews, there is a process already in place within MPFT where they will undertake an internal, but because they are also a community team, they will go down the result of, sort of learning from death process as well. So they will be picked up through that process outside of the MPFT internal review. Okay. And I'm sure, Paul, you may be able to pick up that medical exam in a bit more.
Just if I could, Paul, before you come in, thanks, Becky. Just noting, any increase or whatever through that process, that would be picked up again through quality and safety and then reported back to the board. Okay, so if we keep a handle on that. I'm sorry if I'm just going to hold this for another couple of questions if I can. Just on the community mental health CPA migration to the new system, again, it was just unclear from the report in 2.4. Is that a county-wide change in the care management of people with mental health issues? And will they still be able to, despite the app, because people may have, particularly in some of those groups, might have digital poverty, will there be an opportunity for people still to be able to access their care plan?
Yeah, so absolutely. It's a nationally mandated change around the CPA. So Combined have highlighted their progress against that national ask, and all of our providers are working along the same lines in terms of responding to that mandate. With regards to the digital, discussions have been had whilst there is a push for us to use the apps. there is also alternatives that can be bespoke to the individual. So if the individual opts out, then there are, you know, sort of the processes that we already have in terms of contacting your key worker, having access to referral information, and paper-based really. So there is an awful lot of information still available to people if they cannot get access to that.
Okay. Thanks, Becky. Bucky? Has it turned red?
Keep talking. Well, it's red now. Thank you. I just wanted to add that this is not instead of, and as has been said, it's done in collaboration with the service users. So it's their preferred way of being seen. So it's not either or, it's just good practice and highlighting that some people may need or prefer that mode. So it's not something that we're going to change. And just to add, for additional assurance for us, although you know it's a mandated change, we haven't been reporting on it yet, but we think we're at a stage where we'll move to shadow reporting. That'll give us additional assurance instead of just focusing on what will be phased out, which is the CPA approach.
Thanks, Bucky. Thanks, Becky. That's really helpful. And just very finally, if I can, just in terms, I was going to raise this under performance, but I'll raise it now because it's been discussed in a number of forums. The SDF funding removal for people with learning difficulties and autism. I just wanted to ask how that's going to be monitored in terms of the impact on those communities.
Yes, certainly. It was taken through our QIA assurance process, and as a result, a recommendation was made that we monitor this through FPC and also our Quality Safety Committee, so that we can identify where we are impacting upon or otherwise around the decisions that we've made. So it will be reported into both of those forums.
Thank you, Becky. Okay, just take any further questions on the quality report, Josie.
On the impact of that decision that had to be made, and we both myself and Megan are very acutely aware that that's an area of concern, so it's on our list.
Thank you, Josie. Okay, so just double check, everybody happy to be assured in relation to the key quality assurance and patient safety activity undertaken in respect to the matters relevant to all parts of the integrated care system. So Becky, Josie, thank you very much for the report. If we could then move into item 11, the finance and performance report. And Paul, if I hand over to you first, and then to Phil, and then to Megan.
Yeah, thank you, Chair. Yes, if I can cover the 2023-24 financial position. As I said earlier, the Centre have now agreed an allowance that we can make a deficit this year as a system of 91 million. That is obviously helpful news. Pleased to say that our system has worked really well together as always on this. Combined and MPFT were both on course to make a surplus. They've returned that to the ICB, so that 91 million sits in the ICB, and then we have break-even positions in the three trusts. So that movement was appreciated, and I think right, because the system risk, which we recognised when we set the plan, was taken into the ICB position at the start. I just wanted to make a point, Chair, that the fact that the ICB holds the deficit, I personally think is still a positive thing. It does result in a lot of pressure for the ICB in terms of scrutiny from regulators, has to be said. But I think it's important that we work together as a system, and having conversations with other systems where in most cases the deficit, I would say most, the deficit sits in providers, particularly acute providers. And those providers, a number of them having significant cash flow problems. But because we've been approved a deficit, we don't have a cash flow situation in our system. We're managing our cash collectively. So there is a positive there, as well as the obvious one of being in it together. I think the other side to this, though, is we shouldn't see this as a bailout. there was a lot of scrutiny on us through the year, and it's been a very, very difficult year, and a year that we can't repeat. We came into the year recognising the pressures. It was very late in the day, to be honest, that we came to allocations were out, and we came to realise the extent of the challenges that we had. And so we went into the year with open eyes as a system, I think, in terms of recognising the extent of risk that we were taking into the year. That can't continue. And it's been made very, very clear to me that we've been given special dispensation for two reasons. One, because the centre observed that we work very well together, and they go to some systems and they don't see that. We agree the numbers as CFOs, chief executives agree the position. We have a collective response, and that's counted in our favour. And the second thing is the work that we're doing on the CHC collaborative has reached national eyes and is recognised to be, you know, a really strong model of system partnership, where we're actually delivering some real savings, and we're up to 43 million of cash savings on the CHC programme. So for those two reasons, we were treated, I think, differently to some systems, and we were given agreement to the 91. But that comes with it a very heavy weight of responsibility now, because the expectation is that, having done that and given us that support, we are going to now turn this around. So really, I think, Chair, that's the message, is that we shouldn't sit back and say, great. We should recognise that we've been supportive for the reasons I've said, but this needs to be the point at which we make the turnaround. Finally, we do think we can hit the 91 now. We have month 9 figures in front of us. We're reporting here month 8. We're looking like we should be able to hit that number. We've still some residual risk to manage. There's further savings required from CHC, but the trajectory there is strong, so we are optimistic that we will achieve that. There is some residual risk in terms of out of system contracts, particularly with the Elective Recovery Fund, and some of the providers and other systems have levied invoices on us just before Christmas, which we are disputing, and we must dispute them because they're not valid in my view. But if they were accepted, they would take us above the 91 million. So there is some residual risk, Chair, but overall, as CFOs, we feel reasonably positive we can manage the position now to 91. And I'll come back later and talk a bit more about what all that means in terms of 24-25. Thank you.
Thanks, Paul. Just before we get into any questions, can I just remind people to turn your mic off when you've finished speaking, and remind people to use the microphone button in front of them when it glows red. People online are just struggling to hear some of the points that are being made. So we can just make sure we follow that discipline. Okay, Paul, thank you for introducing that. I guess just 2 quick points. I think it's very helpful that we had the meeting on Monday, the 15th, with the wider group, the local authorities, health chairs, chief executives, non-executive members of the Finance and Performance Committee, and other colleagues joining for that discussion. And I know that through Peter and the chief exec group, there is an event planned for the 24th of this month, which brings the wider executive community together to review this year, but most importantly, the planning for next year and how we're going to tackle that. So I think it's important to acknowledge that. So take some questions colleagues have got. John?
So my question's on the performance side, if that's okay. So 2 questions. One, as the children's portfolio champion, I'm getting increasingly worried about the reduction in access to community mental health services for children and young people. We've seen a really significant drop in access this year, and we've seen a corresponding increase in the amount we're spending on acute. I don't know if those 2 things are related. I don't know if it is or isn't, but it's not a trend in the right direction. So I'd just like some reassurance really about what we're doing to correct that position. And if I just give my second one and then I'll shut up. I just noted on the urgent care side that although we've set up the ambulatory care area within the hospital with the 8 reclining chairs, which is brilliant, the report says that it's being underutilised, and I just wondered why that is, if we've got a lack of frailty triage or something of that type. So they're my two questions. Thank you.
Thanks, John. Chris?
Yeah, so just on the CYP access, it is a data quality issue. So it's certainly the case when you look at the data that we've got available to at the moment, that the target for the end of March increases beyond the baseline we started with in April 2023. Current performance is on a downward trajectory, so it does look as though we're under target and we're not going to achieve the target by the end of March. I think when you drill into that data, the reduction is wholly attributable to Stoke as it happens, but we think that's a data quality issue with colleagues at North Staffs combined, and we've raised those issues with colleagues, and we're just working through now just to make sure that we understand the underlying position, which we think is better than what the data is telling us.
Yeah, but alignment with that, Chris, alignment with points John's making, so the local authority is linked into that process.
And so we monitor the, it's part of the Children and Young People dashboard that comes to the Children and Young People's Portfolio Board, which happens to be next week.
Thank you. And on the urgent care, I think it was John you touched on. Phil?
Thank you, John. Yes, and as I'll come on to in my update, we've seen a decline in our 4-hour ED performance over recent weeks, and that is linked largely to the use of our ambulatory areas because of the pressures and the risk that the department's been holding. We've been having to have non-ambulatory patients within ambulatory areas, which has meant we've not been able to use the area in a way that is designed to. That is now being improved, but it is a result of the pressures we've been under that situation's happened.
Thanks, Phil. Thanks for the question, John. Julie?
Mine builds on really what John has said, and it links to 24-25 planning. So there's a really useful slide deck within the slide deck around where each of the portfolios are. There's a lot of grey, amber, not a lot of green. And so it's alluded to in Megan's report as well, is just understanding the relationship of the delivery of the 24-25 plan in relation to the portfolios and how that is being monitored more in depth, or is it at finance and performance? You allude to it, I think, Megan, and whether there needs to be any of that discussion at board. But it takes me into 24-25 planning, is how our portfolio leads involved in 24-25 planning, so that when we look at the delivery of the portfolios, it will be improved, if that makes sense, the relationship between them.
It does. You actually picked up a point I'd taken as well, Julie, from the papers. So who just wants to respond to Julie on that? Peter?
My suggestion is we take it as a 24-25 planning item on the agenda, so maybe we take it in the rounds as part of that conversation.
Okay, happy, Julie? Yeah, thank you, Peter. Showcat?
Thank you, Chair. So this might be linked to what Peter has said. So I was just trying to understand exactly what the quantum of savings were for 24-25, and then linking to Julie's question, it was how that split across each of the portfolios.
Okay. You mean 23-24? You mean 24-25? We're currently talking about 23-24. Should we come back to it again when we talk about 25?
Put that up there. Yeah. Okay. So everybody happy to move on, Paul?
We've got the rest of the performance report to go, haven't we, with
Okay,
Phil?
you were going to come back on. Yep. Yeah. Phil?
Thank you. Thanks, Chair. So since last board, very challenging Christmas and New Year period with further pressure linked to the industrial action periods that we've had. System capacity and escalation processes have been deployed, and we've put in some additional mitigation as well where there have been gaps. Numerically, looking at the demand we've seen for services, it's been within what we modelled, what we expected. However, within that, there's some variation. So, for example, there were 700 more ambulance conveyances to Royal Stoke during December versus December last year. So there are some quite significant movements within there. COVID levels also remain fairly high and static, I think around 100 inpatients at any one time. We went into Christmas with 85% bed occupancy, which was the target I was discussing at the last board, which meant that we did have beds and capacity to see us through the immediate few days of Christmas, but it obviously became more challenging as we worked through. We have seen some improvements. Certainly our medically fit for discharge levels have remained significantly better than what we expected them to be through our modelling, and that's a credit to all of the partners because everybody works together to ensure that timely flow out of hospital. Our ambulance category 2 response time, the national target that we have through the operational plan for this year, the target is 30 minutes. We were during the Christmas to New Year week, we were 50 minutes against that target, but that is improved compared to 3 hours for the same period last year. And we've seen some deterioration during the start of the year, but we're now running at around 37 minutes in the latest report. So certainly there is improvement compared to last year, picking up Julie's point from earlier. But despite this, we've still remained amongst the most challenging systems within the region and nationally in terms of our category 2 response times, ambulance hours lost at hospital. We implemented our new escalation process for ambulance waits, which again I discussed at the last board, and since implementation we've had 10 7-hour ambulance waits and 2 8-hour ambulance waits. There's a thematic review underway around those, so we'll be able to feed in the learning and themes from those going forwards. So recognising the impact the urgent emergency care pressures continue to have on our residents, so we are relentlessly working to agree tactical responses and ensure that we're maintaining flow and managing risk across our system. The specific areas, 3 of them that I would just want to bring to the board's attention now, are firstly around acute care at home, which is our admission avoidance services. They have been very fragile over recent weeks, and I'm very grateful to the support that the whole system's put in terms of deploying resource from elsewhere, particularly community teams, into that service to enable us to respond and provide that support to patients and avoid unnecessary conveyance to hospital. But it is a fragile service and it's something that we've escalated on the risk register and need further focus on. There has been an impact on our elective delivery because we've had to take the decision to increase outlying medical patients into surgical spaces. And we're trying to minimise that and ensure it's not affecting urgent and cancer work, but some of our waiters, people on the waiting list are indeed experiencing cancellations as a result of that. We've also got to focus around our processes and discharges, particularly around simple discharges, those being discharged from hospital without support. Looking ahead, and this probably feeds a bit into the planning piece, we're trying to look broader at our system in terms of the geography and the resource that's there, the level of ambulance conveyances that we have per head of population compared to other places, the impact our geography and ambulance resourcing has on that, and also at capacity, both in terms of the receiving and processing capacity, ability to cope with spikes in demand, and overall bed-based capacity. Last point, just around elective delivery and cancer. We've maintained our cancer capacity, as I've already mentioned, and we are within trajectory for our backlog reductions for cancer, which I think is really positive. But our elective programme overall has been severely impacted once again through the industrial action, and we ended December with 131 78-week waiters at UH&M and a further 13 at Nuffield. We're currently trying to work through our route to zero there, aiming to do what we can by the end of the financial year, but there are some challenge specialties within that, so we're continuing to link with regional and national colleagues in that space, and also we're having to plan in the background for further periods of industrial action which may have further impact on that delivery. Thank you.
Thanks, Phil. Very full report and summary of the activity that's going on across the system at the moment. Just take any points on the performance report that anybody wants to raise. Self-explanatory, probably. Julie?
I just wanted to comment on the observation about the geographical coverage for West Midlands Ambulance. If you think of the coverage from both perspectives, both from acute but from their perspective, it's huge geographical area.
Yeah.
I think work around that would be really useful in this venture.
Thanks, Julie. Okay, if everybody's happy, Megan, can I ask you to just give us the escalations from the Finance and Performance Committee?
Thank you. There are just a few things I wanted to raise, if we've got time for that. The acute care at home, Phil's mentioned, and it has come up at several committee meetings now, and we will continue to focus on it going forward. Just a couple of additional performance issues which haven't been raised so far today. One was around continued pressure on psychiatric intensive care beds within the system. And the second was around autism assessment weights for children and young people, which have increased by between 1 and 2 weeks across the system. Moving on, I just wanted to pick up under the system recovery plan update that the admissions avoidance and care home priorities remain very challenged and have been largely regulated for the past 2 months. They are key to delivering our recovery plan, so I think it is important that we actually make sure we've got sufficient resource in these areas. In relation to the system business cases, under the double up process, three business cases came forwards. One of those has been looked at again. 2 business cases that remained, one around neonatal and one around obstetrics and gynecology workforce. We had a very robust discussion within the committee in relation to both those. And while the committee agreed with the need for additional investment, there was no source of funding identified. So the committee requested that the System Chief Executives Group consider these business cases in the light of that. The System Chief Executives Group supported both business cases, and on the back of that, the committee has subsequently approved both cases to go forward. It is clear, however, that from this that we need to identify a better way of anticipating in-year pressures in 24-25, and we can come on to that discussion later on the agenda. And then the final one I wanted to raise was the last one in the report around the Primary Care Forum report. That's just in relation to dental funding, and that funding associated with clawbacks has been used to support the ICB deficit position, which means that schemes that have been developed for improving access to dental care will not be able to proceed in the current year. And that's obviously a disappointment in a system where there are some challenges around dental health. Thank you.
Thank you, Megan. Very comprehensive report. Just pause if there are any issues that anybody wants to raise on Megan's report or the performance report. Okay, so everybody is happy to receive the report and take assurance regarding the reports that have been submitted. Okay. Something going on the Oliver, can I just ask you if you'd go on mute, please, and turn your camera off. Thank you. Okay, so if we could then move into item 12, the 24-25 planning round. And Paul, you're going to begin with enclosure 11, yeah?
Yes, thanks, Cheryl. I'll start this off, and then Chris is going to talk about the joint forward plan. So I'll be talking about the operating plan for 24-25. I just wanted to start by just pointing to page 131 of the bundle, which is the work that's been undertaken across the system to look at what our prioritisation framework should be for the new year. This has been widely shared with colleagues across the system and importantly by our Health and Care Senate, and point to the 2 key aims that we've put in the centre of that, sort of safe, timely, sustainable care as one, and secondly, meeting the capacity challenge, because clearly we go into the year with those 2 things very centre of what we need to do: maintain safe care and meet our challenges in terms of the capacity that we need to deliver our healthcare. I start with that, but then go on to a however. The however is that the financial outlook is extremely challenged. We talked about the 91 million deficit in the current year. That's effectively flows through into the new year. That's our start position. The allocations, whilst, as we said earlier, we don't get to know them for sure. What we've seen indicates there's going to be no growth at all, probably negative growth, because inflation looks like it's outstripping NHS resources. So clearly you can see that we're going to have effectively less money next year than we do this. So that's the context of the planning, I'm afraid, that we need to undertake. The CHC part of the recovery, we've talked about a few times, and that is working really well. That does give us some full year effect benefit next year, which is obviously very helpful and very important. But it's quite clear that that's not enough in its own. So the work that we're undertaking, you referred to earlier, Chair, on next Wednesday as an executive, is really starting to think through how do we provide those safe and sustainable services and meet the capacity challenges in that environment of a shrinking financial envelope. We've agreed that to do that, we need it to be clinically led. So CFOs, we've done the kind of the number crunching. That's gone out to the system. It's all provisional, as I say, because we don't know the allocations, but it gives a flavour. On the 24th, we're going to step back, and it's going to be a clinically run conversation about really the art of the possible. And Paul is going to help kick that off to give a medical perspective. Marie, the chief nurse at UHM, will be talking about that from a nursing perspective too. That will really frame the event, and then we're going to get down to some working groups where we've divided the task up into chunks, and it's going to be a very concentrated event, supported by evidence. A lot of work's gone on in preparation for this event to build an evidence pack, so we will have a lot of evidence before us, and we're very hopeful. We've got the groundwork of working well together as a system, so I'm sure people are going to come in with a positive frame of mind. But the message to the board is that it won't be easy. It won't be easy at all. But there is that determination now to get on top of this and create a sustainable plan for the new year. Chair, I think that's all I was going to say by way of the operating plan. As I say, perhaps go next to Chris before we open up for conversation, because it does feed on to the longer term plan that Chris is leading.
Yeah, thank you, Paul. Chris.
Yeah, thank you, Chair. Thank you, Paul. So the joint forward plan obviously sits between the 1 year operational plan and our ICP strategy. It covers a 5-year period and was published for the first time at the end of June 2023. So it's perhaps a bit early in that cycle really to be doing a complete review. We had locally sketched out a process for a refresh, recognising that we are required to review it at least once a year, pending national guidance. So that national guidance has now been released, and having assessed it, there is no material impact for us in terms of the plans that we'd sketched out. So essentially it will be a refresh process, and there'll be a range of inputs into that refresh process. So the first will be updating and reinforcing our kind of strategic direction of travel. There were elements within the original JFP that we touched on, but we didn't particularly expand on. So things like our neighbourhood and locality approach, for example, where the plans have evolved in year. There is new national guidance that's been published since the JFP was live, particularly around maternity, particularly around, say, primary care access, and we'll need to reflect that in. And then I guess to the question earlier, there is active engagement then with the portfolios and an opportunity for them to refresh their own portfolio approaches and plans, whether that might be recovery against poor performance that we've seen in year, or refreshed and revised plans in the light of new guidance that's come out. So that'll be approach over the next few weeks. A particular feature of the joint forward plan is that we do need statements of support from the 2 health and wellbeing boards, that the JFP accurately and adequately reflects the ambitions of the 2 health and wellbeing boards in its content, and you'll see within the planning timeline that we've got that lined up, and we've already presented to the health and wellbeing boards to make sure that conversation is an active and productive one. I think Stoke updated their JSNA reasonably recently. Staffordshire will be updating their JSNA by the end of February, so that'll give us the rich material to reflect into the JFP. There is just an issue about sequencing that we'll need to work through, because I think the Stoke Health and Wellbeing Board is after the March ICB board. So as with last time, when we get to that point, we may be asking for colleagues to delegate the final sign off of the final version with the health and wellbeing statements in to yourself as chair and Peter as chief exec, which as I say is a repeat of the process we had in June.
Thanks, Chris, for that, and sure there will be a certain amount of flexibility in being able to achieve that. So any comments on this work in progress, Julie?
So just a couple of things. I'm not entirely clear, because they're not different things. Is that 24-25 plan, joint forward plan, that our portfolios are delivering? So the resources that are allocated through 24-25 joint forward plan are delivering through the portfolios. I'm not quite convinced I understand the connection between them and the involvement of the portfolio leads in bidding for or understanding how we pull together the 24-25 requirements. That's my first question. The second thing is, and Paul alluded to it, it was very late in the year, last year or this year, when we actually received allocations. And we've got this guidance that nothing's going to really change in terms of, and you've said about flat cash or etc. But are we going to be in a position to make sure, if you like, in the absence of having that we're ready to go on the 1st of April? So that's not waiting for that allocation. So it's, I don't quite get the connection, I don't think.
Yeah, thanks, Julie. Paul?
Yeah, it's a really good observation, Julie, to be fair. So just to give you a practical answer to your point about the portfolios in terms of what we're going to do. So I was working through this yesterday with the CFOs. So we're going to create effectively a matrix, if you can imagine that, of organisations and portfolios, because portfolios, as we know, the whole purpose of portfolios is they go across organisations, they cover the whole system. So the savings target that we have will be divided in those two different ways. And we'll be, Peter's been pushing this. We want the portfolios will have clear objectives and targets, which will obviously key one of those will be around the financial delivery, but the whole range of the planning performance. But it's that sort of those connections between the portfolios and the organisations that are key. That is key, isn't it? So that there's clarity around who's doing what. So hopefully that gives you some practical assurance that we are onto the point that you make. In terms of not waiting, absolutely. I think that the lesson from last year, numerous conversations with the centre where we said we can't find a balance, and the answer was we need to go and find a balance, but we can't. We lost a lot of time in that. It's very clear now. We know enough to know that we do not have sufficient resources. So the conversations we're having now, at this moment in time, we weren't having this time last year, and it's difficult, but at least we're having them now. So I can't give you assurance that we're going to get to a break-even plan. I can't say that, but what I can give you assurance about is that the whole system is completely sighted on the scale of the opportunity and is working flat out to try and get there.
Thanks, Paul. Julie, thanks for the question. Chris?
I think the question of the relationship and the interplay between our different plans is a really good one. Actually, I think at one point we did dedicate a board development session to that, and it may well be that we can recycle and recirculate some of the material there. But I mean, to my mind, we have the ICP strategy for ourselves as the widest partnership, focused around the kind of life course. The joint forward plan is the ICB's partners' response to how the changes we will make for how we will deliver the ambitions articulated in the ICP strategy, and then the operational plan should really essentially be a 1-year snap off of that JFP. I guess by its nature, it's probably focused more on finance and operational targets, but there are elements of projects and programs we will need to deliver in 24-25 that play more to the JFP and less to kind of KPIs and finance. So there is a complexity in that relationship, I think. And as I say, I think we've got some material that we might just recirculate.
Thanks, Chris. Okay, so if everybody's had ample opportunity to ask questions on that, just going to the recommendations, we're noting the 24-25 operational plan priorities approved by the System Finance and Performance Committee. Note the summary of the National Planning Guidance and noting the next steps around the system event on the 24th of January of the broader planning next steps. So everybody happy to do that? Thank you. Item 13 is the Freedom to Speak Up policy, very important document that's received scrutiny through the People, Culture and Inclusion Committee, and their recommendation to the board is that we ratify their approval of the policy. Rather than introducing that and going through it in detail, I'd just like to ask if there are any points of exception that anybody has on this important document. And Showkat, while people are just thinking about that, happy just to take any points from you if there was anything at the committee that you want to raise in advance of us doing that.
Yeah, Chair, there's nothing I really want to raise. We had quite a lengthy discussion about this. We think it's practical in terms of what we're putting forward. So hopefully everyone can support it.
Thank you. So if everybody's happy, we will support and ratify the attached policy that was approved by the People and Culture Inclusion Committee on the 13th of September. So into committee assurance reports, item 14 is the audit committee report. Julie, any exceptions you want to bring to the board's attention?
Just very quickly, take the report as read. I'd really like to commend the work that's been completed, which has culminated in the latest EPR assessment of substantial compliance. A lot of work around this, which has been really good. I've raised today the 2 internal audit reports, one in respect of efficiencies and other pods, which have both been referred to Finance and Performance Committee. Later today, we've got a development session around the governance review. And just to note, the committee approved the amendments to the scheme of reservation and delegation.
Julie, thank you for that. And it was good to see in the report Jane Chapman's recognition of the considerable work that Jane's done over a 40-year career, I think, in the NHS. So nice to note that and wish her well. Any points anybody wants to raise with Julie? Thank you, Julie. We received the report and take assurance regarding that report. People, Culture and Inclusion Committee, Showkat.
Yeah, thank you, Chair. Just very briefly, we had, as you would expect, quite a lengthy discussion around the financial framework and the challenges and how that links to the operational workforce plan, and in particular, some of the risks associated with that. Next month, there is a planned deep dive with the board. So we're really looking forward to that. And there's been some planning going on about our approach and the particular areas and workforce planning that we need to discuss. So we'll pick that up further in February.
Thanks, Showkat. Just pause if there are any issues anybody wants to raise on the report. No, so we'll take assurance regarding the report provided by the People, Culture and Inclusion Committee. Moving into any other business, I've not had any other business notified to me in advance of the meeting, but I'll just pause in case there is any urgent items anybody needs to raise. Okay, thank you. And we'll move into questions from the floor if we can. And just before we do that, Tracy, can I just check if we've received any questions online that we need to pick up?
No, Chair, and as it's a Teams meeting, hands can be raised by the members of the public and the team will look to see if that's happened.
Okay, thank you for that reminder, Tracy. So if anybody online has a question they wish to raise, please do raise your hand. Otherwise, I will take questions from the floor. Ian.
Thank you, Chair. Wish everybody a happy new year. It's going to be a bit of a struggle this year, but I wish you all the best.
Ian, can you just hold the microphone
I'm
a bit
sorry.
closer? And it's quite difficult to hear with the acoustics without the
Can
microphone.
you hear me now?
Yeah, I can. Thank you.
Okay, cool. I'm better without this, frankly. But right, one of the pressures on your finances is inflation with medicines and primary care. Is there any indication of a slowing down of that inflationary rate for medicines?
Paul?
Yes, I'm pleased to say there is, Ian, but there is a show of slowing down of costs. So we saw it spiking about sort of 12-13% back in the spring. It's flattening a lot, basically. I mean, it's sort of 2-3% at the moment. So going in the right direction.
Thank you. My other questions around mental health and LD and autism. Over a year ago, I asked a question about inappropriate adult acute out of area placements. And I think at that time it was about 124 over plan. And now it's over 150 over plan. One of the main drivers is the lack of psychiatric intensive care unit beds for women. I also asked a similar question at Combined's annual general meeting. This seems to be extremely sticky situation. Is there any light on the horizon that this can be addressed in the medium term?
Thank you, Ian. Chris?
So we have experienced sustained pressure. I think it's fair to say. I can't quite see if I turn around, Ian, because of the sun coming in. So the target is for 0 inappropriate out of area bed days. So when we talk about 124, 150, they are bed days. They're not individual patients necessarily. And you are right to say that our PICU capacity is constrained, particularly for female PICU. And we have had a number of initiatives over the past 12, 24 months. We are again looking at the issues raised, and there is a proposition that's coming through to Finance Performance Committee scheduled for Q4.
Thanks, Chris. Ian?
Thank you. And it's already been raised, but this the removal of learning disability and autism SDF funding. On page 8, you've got a series of bullet points which the quality impact assessment raised. On their own, one of those bullet points is quite worrying enough. The 7 bullet points are extremely worrying. Well, I know this has been raised by yourself, Chair, and it's been raised within the meeting. Will you be reporting the mitigations regarding what the bullet points the quality impact assessment has identified, and will be reported publicly?
Thank you, Ian. Becky, and take it those will come through quality and safety and back to the board.
Yeah, we identified obviously the areas of concern, and we've identified that the impacts will be measured at both F&P and Quality Safety Committee. Megan and Josie have already identified that they are equally concerned, and so in terms of some of that, so we will make sure that that is monitored through those processes, so that we can properly understand that decision making, such impacts upon patients going forward.
Thanks, Becky. Thank you, Ian. Thanks very much. Just double check. We've had no hands raised, I don't think, online. Any further questions received? So we'll move on if we can. Just going back to item 18, we referred to the compact at the beginning of the meeting. I just want to double check that colleagues feel the meeting has been effective. We've covered quite a lot of ground this afternoon, which I think has been helpful. Everybody happy with the conduct of the meeting, and that we've adhered to the behavioural compact that we set ourselves. Okay, thank you. So we'll close the meeting at that point if we can. The date and time of the next meeting is the 15th of February. It'll be at 1 o'clock. It will be held in public, but it will be via Microsoft Teams. Can I thank everybody for their attendance and contribution this afternoon, everybody online for their attendance, and once again, if I could thank Councillor Ashworth and John Rouse for their hospitality this afternoon to enable us to hold the meeting in the city of Stoke-on-Trent. Thank you.